Hello everybody and welcome to our module on general anesthetics. So an anesthetic is a drug that produces one or more of four different things. It can produce analgesia so you don't feel pain. It can produce loss of consciousness. It can produce amnesia so you don't remember something. And then it can reduce muscle relaxation or paralysis. I think of anesthetics as coming in four different classes. The first two types are the inhaled anesthetics and the intravenous anesthetics, and those are the ones we're going to talk about in this module. These drugs are usually used to do what we call put people to sleep for surgical procedures or other medical interventions. Then there are the local anesthetics, which numb the skin or nerves, and I talk about these in a separate module. And finally, there are the neuromuscular blocking agents, and these paralyze patients, and we have a separate module on that as well. So we're going to start by talking about inhaled anesthetics, and these are drugs that a patient inhales, and they have some special properties we talk about with respect to these gases that determine their effectiveness. We don't talk about these things for IV drugs or local anesthetics or paralytics. So the special properties that determine how effective a gaseous anesthetic are the solubility of the gas for blood. This is what determines how quickly the activity of the anesthetic comes on and goes off for a patient. And then we're going to talk about the solubility of the gas for lipids, and this is what determines how potent it is, meaning how much of the drug you need to get to generate an anesthetic effect. The first anesthetic property we're going to talk about is called the blood solubility. So in order to understand this, I want you to imagine a tank that is filled halfway up with blood like I've drawn right here. And now imagine you begin bubbling in gas molecules of an anesthetic through a pipe on the bottom. Initially, those gas molecules will all dissolve in the blood. None of them will persist in the gaseous form and head up and float above the blood because they will all completely dissolve. As time goes on, however, so many anesthetic molecules will dissolve in the blood that it will be saturated. It will have absorbed all the gas molecules it can, and at that point, gas molecules will begin to escape out into the gaseous form and hover above the blood. And then if you keep putting in anesthetic, you will begin to fill up the space above the blood in the tank with gas molecules. Now, the way we measure the amount of molecules in the gaseous form is by something called the partial pressure. So if we plotted that over time as we're filling this tank with anesthetics, initially there would be very low partial pressure because all the gas molecules are dissolving in the blood. And then as the blood becomes saturated, the partial pressure will begin to rise, and then eventually it will meet a peak up here where you are filling the space above the blood inside the tank. So the reason I went through that whole exercise is because molecules dissolved in blood do not exert an anesthetic effect. Molecules not dissolved in blood do exert an anesthetic effect. And so based on the thought experiment we just did, you need to saturate the blood to generate a partial pressure and get the anesthetic effect. So the more soluble a gaseous anesthetic is in the blood, the longer it will take for its effect to be exerted on the body. So just to summarize this, because it's an important point, when you put a gas anesthetic into the lungs, into the alveoli, it must saturate the blood first, and then it will begin to exert its effect on the brain, and then it will cause sedation. So this means that a higher solubility of a gas is a higher tendency to stay in the blood, less likely to leave the blood for the gaseous form and then the brain, so a longer time to saturate blood. And what this means in terms of clinical medicine is it will have a slower induction time and a slower washout time. It will take a long time to put a patient to sleep with an anesthetic that has a very high blood solubility. On the other hand, a gas anesthetic with a low solubility will quickly saturate the blood. It will quickly get molecules into that gas form that can exert their effect on the brain. Therefore, there will be a very short induction time for anesthesia and also a short washout time when you turn off the anesthetic gas. So we can evaluate the blood solubility of gas anesthetics by looking at how long it takes for the partial pressure to rise. So imagine that a patient begins inhaling anesthetic B, and we measure the partial pressure of that anesthetic in their bloodstream over time. Anesthetic B takes a long time to rise up to its maximum value where it will yield its maximum anesthesia effect. Drug A, on the other hand, when the patient inhales that, it quickly rises up to its max effect. Therefore, from this graph, you can tell that drug B has a much higher solubility in blood, and therefore it takes a longer time to get up to this max effect. Drug A, on the other hand, has a much lower solubility in blood and therefore rises quickly to the max anesthetic effect. To be able to compare the blood solubility of different gas anesthetics, we determine something called the blood-gas partition coefficient. So this is the concentration of the anesthetic in blood compared to that in alveoli. So for example, for isoflurane, it's 1.4, which means that when you put isoflurane gas in equilibrium with blood, it will be 1.4 times more likely to be found in the blood than in the alveoli. It slightly likes to be in the blood form compared to the gaseous form. And these are some partition coefficients for various anesthetics. So halothane has a very high partition coefficient. That means it likes to be in the blood form. It has a high solubility in blood. On the other hand, nitrous oxide has a very low partition coefficient. That means it is not very soluble in blood, and it likes to be in the gaseous form and quickly exert its effects. And I've sort of summarized these for you down here at the bottom. Now we're going to talk about a different physical property of gas anesthetics, and that's the lipid solubility. Don't confuse this with the blood solubility. They're different physical properties. This is the affinity of gas for lipids, and it's defined by the oil-gas partition coefficient. The more lipid affinity a gas anesthetic has, the more potent it has. That's called the Meyer-Overton rule. So take a look down here at this chart. Halothane, for example, has a very high oil-gas partition coefficient, 224, so it's very potent. It doesn't take a lot of halothane to put someone to sleep. Nitrous oxide, on the other hand, has a very low partition coefficient. It takes a lot of nitrous to put someone to sleep. So the more lipid soluble a gas anesthetic is, the more potent it is, but we actually don't usually talk about the lipid solubility or the oil-gas partition coefficient. Instead, what we talk about is something called the MAC, and that's the minimum alveolar concentration. This is the concentration of anesthetic that prevents movement in 50% of subjects in response to pain. So a drug with a very low MAC means you don't need much concentration of that gas in order to put someone to sleep. It has a high potency. And the MAC of different drugs changes slightly with age, so elderly patients will have a different MAC from younger patients. And the MAC is related to lipid solubility, not blood. Remember, don't confuse those two. And the lipid solubility of blood is equal to 1 over the MAC. So if it's very lipid soluble, it will have a low MAC. And if it's not very lipid soluble, it will have a high MAC. And so here's a summary slide of the physical properties of inhaled anesthetics used to assess its efficacy. So the onset of action of an inhaled anesthetic is determined by the blood-gas partition coefficient. The higher the coefficient, the slower the onset of action for that gas. Similarly, the solubility of the gas in blood determines the onset of action. So a higher solubility in blood means a slower onset of action. Potency, on the other hand, is determined by the oil-gas partition coefficient. So the higher this coefficient, the more potent the anesthetic and the less of that anesthetic you need to induce anesthesia. MAC, on the other hand, is the minimum alveolar concentration, and the lower the MAC, the more potent the agent is. And down here at the bottom, I've shown a graph showing a slow onset gaseous anesthetic, which has a slow upsloping line, and then a fast onset gas anesthetic, which has a very rapidly upsloping line to reach its peak effect. So those are physical properties that are defined for all gaseous anesthetics. But now we're going to talk about specific gas anesthetics, and I've listed them for you here. Desflurane, sevoflurane, halothane, enflurane, isoflurane, methoxyflurane, and nitric oxide. You will mostly see in operating rooms in the United States sevoflurane and isoflurane used. Halothane is a very old anesthetic that's not used anymore, and some of these others also have major side effects not used anymore. You need to know them for your boards, but you're not going to see them used in operating rooms. So there are some common side effects to all of these. They all cause myocardial depression, so they can lower the cardiac output. They all cause respiratory depression. That's why patients are usually intubated when they're receiving these drugs. They can all cause nausea and vomiting. Patients who wake up from surgery often have nausea and vomiting. They all increase the cerebral blood flow. They cause cerebral vasodilation, and blood flow goes up, and intracerebral pressure goes up. And they all decrease the glomerular filtration rate in the kidneys. Some inhaled anesthetics have special side effects you should know about. So halothane is one of them. It can cause very severe and life-threatening hepatotoxicity and also a condition called malignant hyperthermia, which I'll talk about in a minute. The liver toxicity is very dangerous. There's massive liver necrosis and increased AST and ALT, and this is one of the reasons halothane's not used anymore in the United States. Methoxyflurane can cause nephrotoxicity. It's got a metabolite which is renally toxic. And then finally, enflurane can cause seizures. It lowers the seizure threshold in the central nervous system. Malignant hyperthermia is a rare life-threatening reaction that occurs after people receive halothane or succinylcholine, which is a paralytic, for surgery. They'll wake up from surgery with fever and rigid muscles. They'll be tachycardic and their blood pressure gets very high. And they have extensive muscle damage, so they spill potassium into their blood, which can cause arrhythmias, and they spill CK, which can cause renal failure. We think this is caused by something called the ryanodine receptor in the sarcoplasmic reticulum. This is a calcium channel in the sarcoplasmic reticulum of muscles, and it's abnormal in patients who get malignant hyperthermia. We think it's inherited in an autosomal dominant fashion. And this will dump calcium from the sarcoplasmic reticulum, and the calcium will lead to extensive consumption of ATP as the SR tries to reuptake that calcium. Remember, the sarcoplasmic reticulum stores calcium in cells. All that ATP consumption generates heat, and this causes tissue damage, and that's why patients get high fever from this, and it's treated with dantrolene, which is a muscle relaxant. Nitric oxide is a low-potency inhaled anesthetic. It's often used in dentist offices, and the special thing to know about this is that it diffuses rapidly into air spaces in the body and increases the volume. Now, if you're healthy and having a tooth pulled at your dentist office, that's no big deal, but if you have a pneumothorax or if you have abdominal distension from a perfed viscus, then this can cause a doubling of the cavity size, so you cannot use that. It will diffuse into those spaces and make them swell. So now we're going to switch gears and talk about intravenous anesthetics. And these are drugs like barbiturates, benzodiazepines, opioids, etomidate, ketamine, and propofol. And we'll go through each of these in the remainder of this module. So the one barbiturate that can be used as a general anesthetic is thiopental, which is also called pentothal, and it's a GABA drug. It binds to the GABA receptor, although it has a different mechanism from benzos. It's got very high potency because it's highly lipid soluble, and recall that lipid soluble drugs can easily cross the blood-brain barrier. It's got a very rapid onset for that reason, rapid entry into the brain, and it's ultra short acting. And the reason for this is because this drug likes to redistribute into muscle and fat. So the effect will quickly wear off, but it doesn't mean the drug's left the body. It just means the drug is being stored in the muscle and fat. It actually takes a while for it to completely wash out of the body. Side effects of barbiturates are myocardial and respiratory depression, and they also decrease the cerebral blood flow. So benzodiazepines are drugs like midazolam, lorazepam, diazepam, and alprazolam. You may think of these as oral pills we give to people with anxiety disorders, and that's true, but they can also be given IV for anesthesia. They bind to GABA receptors, and they increase the frequency of the GABA ion channel opening. So the GABA receptor allows chloride to go into neurons and make them less likely to depolarize. So these drugs will keep that GABA receptor open longer, and more chloride will go into the neuron. Like I said before, low dosages are used as anti-anxiety drugs, but high dosages will cause sedation and amnesia. They can even be used as an anticonvulsant, and we talk about this in the seizure module. They can cause cardiorespiratory depression, and they can lower the blood pressure. If a patient overdoses on benzos, there is an antidote, and that's flumazenil. And then midazolam, which is Versed, is used for short procedures. So people will get this when they're having an upper endoscopy. It will make them sleepy, and it'll sometimes cause some amnesia, but it washes out very quickly, and then they wake up after the endoscopy and they can go home. Opioids are drugs like morphine, fentanyl, and hydromorphone, and just like benzos, there are oral forms of opioids that we use to treat chronic pain, but they can also be given in higher dosages as IV meds for anesthesia. So they're given as sedatives and analgesics. They don't cause any amnesia, so patients who are treated with opioids will remember everything, and it's important to know that. You want to give another drug along with this if you're going to be putting them through a dangerous procedure. They act on a receptor called the mu receptor in the brain, and they carry side effects like decreased respiratory drive, decreased blood pressure, nausea and vomiting. They will paralyze the gut. People who get opioids often have difficulty moving their bowels after surgery, and they cause urinary retention. And people who take these chronically as pills, this really doesn't apply to anesthesia, but if they take them chronically, they start to lose their effect over time, and this is called tolerance. Let's talk a little bit more about the opioid mechanism, because you're sometimes asked this, especially on step 1. So they bind to those mu receptors, and these are G protein linked, but we don't really know what the second messenger system is. In the autonomic nervous system module, I talked to you about some G protein linked systems where we clearly understand the second messenger. That's not true here. But they do increase the potassium efflux from cells, and this hyperpolarizes cells. It makes it harder for the neuron to conduct an impulse, and that appears to cause less pain transmission. If people overdose on opioids, there's an antidote, and that's naloxone. And this usually doesn't happen with anesthesia, but this happens if people are taking opioids chronically for pain. And it's a mu receptor antagonist, and it competes with opioids and displaces them from the binding site. It reverses the effect of opioids within minutes. And if you ever give this to someone, it's very dramatic. What sometimes happens in the hospital is someone is taking so much pain medication that they start to have respiratory depression and become hypoxic. And if you administer naloxone, within a minute they will wake up and be in extreme pain, because you will instantly reverse all the effects of the opioid drug. Naloxone has to be given IV because it's inactivated by the liver if you give it orally. You should know that patients who take opioids chronically develop tolerance, and this is not really a problem when opioids are used short-term for anesthesia, but it is a problem when people take these drugs chronically for pain. It's especially a problem for people who have cancer pain from metastatic disease. If they take opiates every day, after a while they will become tolerant. And tolerance means that certain effects of the drug wane as you take them over time, so they become less effective in terms of pain. They also cause less side effects like sedation, nausea, vomiting, and respiratory depression after you've been taking them for a while. Opiates are very effective cough suppressants, but this effect wanes with tolerance, and then the effects on urinary retention also go away with time. It's very high yield to know for your boards that there is no tolerance to constipation or meiosis. We don't know why this is the case, but these two effects persist even in patients who've been on the drug for a long period of time. Next drug we'll talk about is ketamine, and ketamine is a PCP derivative. So PCP is phenylcyclidine. It's also called angel dust. It's a street drug, and it's abused by people because it causes analgesia, but it can also make people hallucinate, and sometimes there are high-profile arrests of violent criminals who get very violent when they're taking PCP, and they get very aggressive. So just like PCP, ketamine is an NMDA receptor antagonist, and the NMDA receptor is a receptor activated by glutamate in the central nervous system. Ketamine is a dissociative drug, so patients enter a trance-like state. They have analgesia and amnesia. They won't remember anything. And the good thing about ketamine is it has few respiratory or cardiovascular side effects. It can make the blood pressure go up and the heart rate go up, but it doesn't depress the systems as much as some of the other drugs. If ketamine is used alone as an anesthetic, patients will have what are called emergence reactions when they wake up. They'll be very disoriented. They can hallucinate and feel like they've had dreams. This can be very frightening to patients. It can occur for a few hours after surgery. So if you co-administer ketamine with midazolam, a benzodiazepine, it will often help to prevent these emergence reactions from the drug. Etomidate is a drug that modulates the GABA receptors and it blocks neuroexcitation. It causes anesthesia but not analgesia, so patients can still feel pain when they're on this drug even though they may be asleep. It's relatively hemodynamically neutral, so it's good for hypotensive patients, and its major side effect is that it blocks cortisol synthesis, so there are reports of people becoming adrenally insufficient after getting this drug. And the place where it's most commonly used is rapid sequence intubation. So if you're ever in the hospital and a patient's in severe respiratory distress and needs to be emergently placed on a ventilator, an anesthesiologist will do what's called rapid sequence intubation. They'll administer etomidate because it's got a very quick onset of anesthesia and it will put the patient to sleep. They'll usually also give succinylcholine, which paralyzes the patient, and then they can put them on a breathing tube very quickly. The etomidate and succinylcholine both wash out very fast, so shortly thereafter they'll wake up on the ventilator and then they're given an IV drug for sedation while they're on the respirator. And that's called rapid sequence intubation. And propofol is a very commonly used anesthetic in operating rooms and also in the ICU for people who are on the ventilator. It's a GABA modulator. It puts people to sleep and they don't remember anything after the drug. It can cause myocardial depression and hypotension. It's a milky white substance that you drip into people's veins, and it's very effective as an anesthetic. So just to review, there are a number of anesthetics that work through the GABA receptor: etomidate, propofol, benzos, barbiturates, and remember that GABA is largely an inhibitory neurotransmitter, so when you activate this system you get sedation, and that's why these drugs are effective as anesthetics. Let me finish by just telling you a little bit about how these drugs are used in actual practice. Anesthesiologists talk about induction and maintenance in terms of general anesthesia. So induction is when they want to put a patient to sleep, and for this they use intravenous drugs like propofol, etomidate, or ketamine, and these quickly put the patient to sleep. Once the patient is asleep, they maintain the anesthesia either using IV propofol or an inhaled anesthetic like sevoflurane or desflurane. And so this is just the way these drugs are used, especially the inhaled ones you should know are typically used for maintenance and not to actually put someone to sleep. So just to give you an example of how these drugs are used in combination in a real case, I often go down to the operating room to take images of the heart during open heart surgery. And so what the anesthesiologist will do for an open heart case is induce anesthesia with propofol and midazolam. The midazolam gives the patient some amnesia, and so does the propofol, and the propofol puts them to sleep. For the initial portion of the case, they need the patient to be paralyzed as they open the chest, so they'll administer rocuronium, which is a paralytic. And then for maintenance of anesthesia during the long open heart case, they'll give sevoflurane inhaled through the ventilator, and they'll also administer fentanyl IV. The sevoflurane keeps the patient asleep, but it doesn't prevent pain. And if the patient has a lot of pain, they can become tachycardic and hypertensive, so giving fentanyl IV at the same time blocks the pain. And so this is an example of how these drugs are used in combination to get someone through a surgery that may be several hours long. And that concludes our module on general anesthesia.